Dr. Subhashni?
Yes, ma'am.
That was a nice presentation, but I just have a doubt. Was it a primary or was it a primary neuroendocrine tumor, or could it be somewhere? Could it be secondary? So, and what is the criteria when you call it a primary neuroendocrine tumor of the seminal vesicle? Dr. Subhashni, can you hear me?
Screen இருக்காங்க.
Rectum
tumors கூட rectal mucinous adenocarcinoma rule out பண்ணாங்களான்னு கேட்கணும். Next from rectum also, I just wanted to know how was colonoscopy or finding.
Dr. Subhashni, can you clarify on that issue, on that point? Yeah.
Can you just repeat, ma'am? I couldn't hear.
I just wanted to know whether it's a primary neuroendocrine or a secondary.
Out ஆச்சு.
அவுட் ஆயிடுச்சு. இன்னைக்கு இன்ஜினியர் வரேன்னு சொல்லிருக்காங்க.
கேப்பா ஃபார்ம் எழுதணும். இன்ஜினியர் வந்து முடிச்சதுக்கு அப்புறம் கேப்பா ஃபார்ம் எழுதணும். என்னையா பேசுறாங்க, என்ன பண்றாங்க?
Other viewers, kindly mute your screen. Mute.
Yes, ma'am. Ma'am, yes, ma'am.
Amma, Dr. Subhashni.
Ma'am, yes, ma'am.
Adamma, the primary neuroendocrine or secondary neuroendocrine? Dr. Subhashni.
Ma'am, it's a primary neuroendocrine, ma'am.
How did you come to a diagnosis of primary? What is the criteria for calling it primary neuroendocrine or secondary neuroendocrine? Subhashni.
Ma'am, it's a primary neuroendocrine. Ma'am, no other lesion. Hello, ma'am. Ma'am, there were no other lesions, ma'am.
Primary. What is the criteria for calling it
Ma'am, it's primary. Ma'am, no other lesion. Hello, ma'am.
Yes,
இதுக்குள்ள இது பண்ணிடுங்க. முடிச்சிட்டீங்களா? இதை நோக்கி
Hello, ma'am. Ma'am, am I audible, ma'am?
Yeah, you're audible, but there's a lot of noise. I don't know from which side. Yeah.
Ma'am, there were no other lesions, ma'am. Ma'am,
Yeah.
am I audible, ma'am?
Yes, ma. Yes, ma. You're audible, but there's a lot of noise. I don't know from which side. Yeah.
Ma'am, there were no other lesions, ma'am.
Okay, ma. Okay.
Ma'am,
Yeah.
am I audible, ma'am?
Yes, ma. Yes, ma. You're audible, but there's a lot of noise. I don't know from which side. If there are no questions, then we can go on to the next case.
Ma'am, there were no other lesions, ma'am.
Okay, ma. Okay, fine.
Ma'am, yeah, am I audible, ma'am?
Yes, ma. Yes, ma. You're audible, but there's a lot of noise. I don't know from which side.
Rectal primary rectal colonoscopic findings சொல்லல டாக்டர்
If
நீங்க.
there are no questions, then we can go on to the next case.
Ma'am, there were no other lesions, ma'am.
Okay, ma'am. Okay, fine.
Ma'am, yeah, audible, ma'am. Yes, ma'am. Yes, ma'am. But it's not.
Ma'am, it's getting repeated.
Rectal primary rectal colonoscopic findings சொல்லல டாக்டர்
If
நீங்க.
there are no questions, then we can go on to the next case. Ma'am, there were no other lesions, ma'am.
Okay, ma'am. Okay, fine.
Ma'am, yeah. Yes, ma'am. Yes, ma'am.
Ma'am, it's getting repeated.
Rectal primary rectal colonoscopic findings சொல்லல டாக்டர்
If
நீங்க.
there are no questions, then we can go on to the next case. Ma'am, there were no other lesions, ma'am.
Okay, ma'am. Okay, fine.
Ma'am, yeah. Yes, ma'am. Yes, ma'am.
இல்ல. Am I audible? Is the next person ready? Can the next person share your screen?
Yes, ma'am.
Dr. Gayatri? Yes?
Yes, ma'am.
Share your
Yes, ma'am. Yes, ma'am. I can share. Can I share now,
screen.
ma'am?
Yeah, please. Is the next person ready? Can the next
Yes.
person share your screen?
Yes, ma'am. Yes, ma'am.
Dr. Gayatri?
Yes, ma'am. Can yes, ma'am. Can I start, ma'am?
Yeah, please, ma. Please continue.
Okay. First of all, I thank my mentors, Professor Dr. Chandra ma'am and Professor Dr. M. Dogulregis ma'am, and good afternoon to everyone present here, ma'am. And then I also thank and express my gratitude to Professor Dr. R. Padmavati ma'am and to all my dear teachers and professors present in MMC. Today, I'm discussing an interesting case that came during my posting in Institute of Child Health at Edmore. So this was an epiphanic moment in a monotonous time. So when this case presented as a 11-year-old male child who came with the complaints of right upper quadrant pain with loss of appetite for 1 month and fever for 3 days, and there was a trauma history 6 months ago, but he wasn't treated up or followed up for that. On examination, there was a firm mass in the right hypochondrium and epigastrium extending to left hypochondrium. It moved with respiration and was about 5 centimeter below the right costal margin. The child was investigated further. The complete blood count was within normal limits, and the liver function test, all the parameters were normal, and the AFP value was also normal. And further, he was investigated by doing USG. In that, the impression was given as hepatomegaly with multiple cystic lesion in solid areas, and the differential diagnosis was given as query hydrated cyst of the liver. And on X-ray, we could see that the bilateral lung fields and cardiac shadow is normal, but there is soft tissue shadow in the right part of the abdomen, and there was no calcification or internal vascularity noted. On plain CT of abdomen, there was a hypodense lesion in the right lobe of liver, which was having some amount of calcification, but no free fluid. So the patient was taken up for contrast-enhanced CT abdomen. On that, we could see that there was a heterogeneous mass with there was a peripheral rim of enhancement. I could show it here. There was a peripheral rim of enhancement, and there were multiple tortuous arteries which were feeding inside the lesion. So there was a dense lesion occupying in the right lobe of liver. And the coronal section proved the same. And the coronal section showed that the spleen as well as bilateral kidneys were.
Type C இல்லாம type B charger. இதுல
Can
பண்ண
I
முடியாது.
And in the axial plane, we could see that this lesion was pushing on to the biliary tract and the portal vein to the left side. And the coronal plane also shows the similar features, but the kidneys and the spleen was unaffected. And the impression was given as a large hepatic space occupying lesion with the following possibilities: embryonal sarcoma and hepatoblastoma. The patient was then operated for hepatic hydatid cyst, PAR procedure, that is percutaneous aspiration, and then irrigation with scolicidal agent and reaspiration was done. And grossly, we received multiple gray-brown, gray-white soft tissue fragments, cystic and solid. And the largest was about 6 x 4 x 1 and smallest 0.5 x 0.5. There was no hepatic cyst material, hydatid cyst material made out grossly. And under low power, we could see that there were multiple spindle-shaped and stellate cells which were arranged in a myxoid stroma. Apart from that, there were some pleomorphic giant cells with some atypical mitosis seen, and focal areas of congested blood vessels, necrosis, and hemorrhage was also seen. And the spindle-shaped cells can be well appreciated under higher power. And in this, we could see the atypical mitotic figures as well as the myxoid stroma with multinucleated giant cells. And we utilized the periodic acid shift stain as for this patient, and it showed multiple cytoplasmic eosinophilic hyaline globules which were PAS positive, and this clinched the diagnosis for us. Apart from that, to rule out other causes of hepatic lesions in childhood, we utilized the use of immunohistochemistry. CD10 showed positivity. Ka67 showed strong nuclear positivity in 60 to 70% of tumor cells. And also, Desmond showed strong cytoplasmic positivity in 50 to 60% tumor cells. And Vimentin also showed positivity in the tumor cells. And Glipican showed cytoplasmic positivity in 30 to 40% of tumor cells, with the myogenin being conspicuously negative for the tumor cells. And this is the microscopic description: spindle and stellate cells along with pleomorphic multinucleated giant cells. And the cells have rather abundant or bubbly eosinophilic cytoplasm with pleomorphic nuclei, and the atypical mitotic figures and eosinophilic PAS positive hyaline globules were seen in the tumor cell cytoplasm. Impression is given as the embryonal sarcoma of liver, and the IHCs also proved the same. We utilized the SMA, smooth muscle actin, to rule out leiomyosarcoma and other soft tissue tumors. Myogenin was used to rule out embryonal rhabdomyosarcoma, one of the most important differential diagnoses. And pan-CK was used to rule out epithelial tumors of liver in childhood. And BCL2 was also utilized to rule out whether there were any lymphoma or any other tumors which presented with spindle cell morphology. And coming to the discussion about embryonal sarcoma of liver, it's also called by various names: malignant mesenchyma, mesenchymal sarcoma, rhabdomyosarcoma of liver. Peak age is 6 to 10 years, and 88% occur below the age of 15 years. Within 2 years, it is the hepatoblastoma. About 10 years, it is hepatocellular carcinoma. So this is the third most common primary liver cancer in pediatric age group, and it is about 0.2% of the total pediatric liver cancers. The annual incidence is about 1 case per million cases. Until now, in literature, less than 60 adult cases and 200 pediatric cases have been reported. Adult cases are much more aggressive in nature, and they present with more asymptomatic. The patient will be asymptomatic or may come incidentally with an abdominal mass, and it has a poorer prognosis as compared to the pediatric cases. It usually arises in conjunction with mesenchymal hamartoma, which is a benign liver neoplasm, which is also composed of solid and cystic masses present inside the mesenchymal hamartoma. So this is the history about the tumor. Wills first described the pathology in 1962 as rhabdomyoblastic mixed tumor. In 1973, Stanley classified it as malignant mesenchyma due to the presence of focal chondroid appearing cells. And finally, in 1978, Stocker and Ishak definitely described the pathology and adopted the term of undifferentiated embryonal sarcoma to describe a mesenchymal hepatic tumor which did not show any specific differentiation. So grossly, they are large, solitary, well-circumscribed tumors with an average diameter of 10 to 30 centimeter, and it's most commonly the right lobe involved here, with multiple areas of necrosis and hemorrhage with cystic degeneration. So it has a variegated appearance, and it is due to an aggressive tumor, it can easily metastasize to the lung, pleura, and peritoneum. And if the patient, the tumor size is more than 30 centimeter, then it carries a poorer prognosis. In IHC, mostly they will become positive for alpha-1 antitrypsin, anti-chymotrypsin, lysozyme, CD10, glypican-3, desmin, and vimentin, and is negative for alpha-fetoprotein and myogenin. So when a case presents in the pediatric age group with an atypical liver lesion and all the lab parameters, including the serum tumor markers, are negative, then we have to think of undifferentiated embryonal sarcoma to be a differential diagnosis, especially when there is a discrepancy between the USG findings and the CT-MRI findings. So when the USG is, in this case, it was given as a cystic mass in the USG, whereas the CT showed, clinched the diagnosis as a solid tumor. But if it is a discrepancy, we have to think about the undifferentiated embryonal sarcoma of liver. And if it is resectable, that is, if it is found out at an earlier stage, but there is no staging for this tumor is unique in that aspect. There's no staging for this tumor. If the size is smaller, then we can resect the tumor and give adjuvant chemotherapy. And if there is a recurrence, we have to consider transplant. If it is not resectable, then if at all we do a frozen section or an open biopsy, then we can give neoadjuvant chemotherapy to the patient consisting of cyclophosphamide, daunorubicin, dactinomycin, and also vincristine. And then we can decrease the size of the tumor and give do surgical excision, which is the curative treatment for the condition of embryonal sarcoma of liver. And one of the most important differential diagnoses in pediatric age group is embryonal rhabdomyosarcoma. Here, the cells will be stellate cells, spindle-shaped cells with deeply acidophilic, eosinophilic cytoplasm will be present. There are quasicellular and hypercellular areas, hypercellular around the blood vessels. And here also we can see pleomorphic tumor giant cells. And this also occasionally can show presence of myxoid stroma, and there is hepatoblastoma mixed form. In this, there is epithelial component in the form of bile ducts, and also mesenchymal component. So hepatoblastoma, this forms an important differential diagnosis in age group less than 2 years. Here, the alpha fetoprotein levels will be increased, whereas in undifferentiated embryonal sarcoma, the AFP levels are usually normal. And in case of embryonal rhabdomyosarcoma, myogenin and MyoD1 are used in IHC to confirm the diagnosis. And in case of imaging differential diagnosis, since it shows a solid and cystic lesion, abscesses, infections, and especially hydatid cyst caused by echinococcus is a differential diagnosis. Here we can appreciate the cyst wall along with the hydatid cyst. This cyst consists of 3 layers. There is an outer layer which is composed of adventitia and fibrous tissue. There is a middle laminated refractile acellular layer and an inner germinal layer which is composed of the daughter cyst and the proctoscolysis, hooklets, etc. There is also hydatid sand composed of the daughter cysts and the hooklets, and this was considered to be the diagnosis for this patient, and the patient was operated by the PAR procedure technique. And there are multiple articles to support the diagnosis where the patient can come with the presence or mimicry of a hydatid cyst, and the final diagnosis will be embryonal sarcoma of liver. And Here, this is another case report and review of literature where the primary undifferentiated embryonal sarcoma is misdiagnosed as hydatid cyst. And this is another case where it was masquerading as a liver abscess. And there, as you can see, there is a tortuous artery which is supplying the periphery of the lesion. And the take-home message of this case is that it is presented here for its rarity and diagnostic challenge. And it was actually diagnosed clinically and radiologically as hydatid cyst and curated and sent to us. And a high index of clinical suspicion can enable a per-op frozen section, and then the treatment can be modified as resection instead of curettage or prior procedure. This case is usually associated with the diagnostic delay because of lack of characteristic clinical features and absence of tumor markers and inconclusive radiological findings. So thank you, ma'am, for your patience.
Thank you, Dr. Gayatri. Thank you, Dr. Gayatri. That was a extensive, that was a clear and complete presentation of a rare case.
Okay, ma'am.
Gayatri,
Yes, ma'am.
very good presentation. You should
Thank
have
you.
gone little slowly. Don't be in a hurry.
Okay.
Maybe time constraint is a factor. You're very well presented and very well given a differential diagnosis. One thing I just want to ask you is
Yes, ma'am.
mesenchymal hematoma. I thought of differential diagnosis in the beginning
Yes,
because the
ma'am.
slides which you have given showed
Yes,
us
ma'am.
stellate cells and then the small fibroblast like things and the
Yes.
vascularity like a necrosis. So
Yes.
I couldn't think beyond that. After the pure picture only we were able to see. Whatever you have shown, we couldn't come to
Yes,
a
ma'am.
conclusion. That, yeah, the one on the right side.
Yes, ma'am.
And then the other low power view you have sent it to us. Not
Yes.
this, the 40x and the picture. But பரவாயில்ல ரொம்ப your highlight was good, but entity made us to have to think in place of a highlighted presentation masking the undifferentiated
Yes,
sound. Good, good.
Yes.
One thing I wanted to add also, ma'am, I'm Dr. Chandra. Ma'am, this
Yeah,
one,
yeah.
they thought it is a cystic lesion. The myxoid areas of the tumor were actually mistaken for a cyst. Scoliosis and the material, no, that infective material which is there inside the hydatid cyst. So they actually had started the procedure and completed the operative procedure as for a hydatid cyst with all the antibiotic coverage and all the other things which will be followed for a hydatid cyst. As per that, the procedure was done. So probably I think they had completely ignored the CT warning that it could be an embryonal sarcoma, in which case they would have gone in for a frozen
If
section.
they would
So
have
that
done
was,
a
yes, ma'am.
frozen
So
is
that is
not
what,
done there.
yeah. So because in spite of the warning,
Madam, you're not, suddenly you went away. You're not audible.
Frozen.
no, ma'am.
Frozen.
Yeah, so CT warning one day it was ignored, I think. CT warning that it could be an embryonal sarcoma was there preoperatively, but somehow they considered the diagnosis of hydatid cyst as the most likely diagnosis. Like, went ahead with the procedure.
end of the day போய் ஒரு ட்ரை காமிச்சா மண்டே பாக்குறேனாங்கன்னா அதை மட்டும் காமிச்சிட்டோம்.
A very good place.
One has to mute their mic.
Open up.
The other participants, kindly mute your screen, please.
Please mute your mics because it is disturbing the presenter. So I would request you to kindly mute your mics. Thank you.
Thank you, Dr. Gayatri, and thank you, Chandra Madam. Can we go on to the next presentation, Dr. Revati? Revati from Institute of IOG and MLC.
Yes, ma'am. I'm ready, ma'am. I will share now.
Yeah, you can share the screen.
Video image video. PPT.
Dr. Revati?
Ma'am, I'm trying to share, ma'am. I'm trying
Okay.
to share, ma'am, but it's coming as log out.
Revati, if it's taking time, Dr. Anita Rani, are you ready?
Yes, ma'am.
Please kindly share your screen. Revati, just wait for some time.
Okay, ma'am. Okay.
Okay. By the time you can sort out that issue and come
Yes,
back.
ma'am.
Dr. Anita,
Yes,
kindly
madam.
share your
Yes,
screen.
madam.
Yeah.
Can I start, madam?
Yeah, please, Dr. Anita, please start.
Good afternoon, all. I thank our respected HOD, Dr. Jamila, madam, for giving me this opportunity. So, a case of 27-year-old female presented with complaints of excessive growth of facial hair, increased acne over the face, deepening of voice, secondary amenorrhea, and weight gain. All these complaints were present for the past 1 year. Hormonal assays were done for evaluation, which showed increased levels of androstenedione, dihydroxyepiandrosterone, testosterone were all increased. Cortisol was within the normal limits, and the same way LH, FSH, prolactin, and estradiol are all normal, and serum electrolytes were also normal. This was the MRI imaging of the patient, which showed a well-defined cystic lesion, 4.5 into 3.1 into 3.4 centimeter, with eccentric T1 hyper and T2 hypo intense solid component containing flow voids seen in the left adnexa. So, with the diagnosis of left ovarian neoplasm, left ovariotomy was done. And we received the specimen of left ovary, measuring 4 into 4 into 3 centimeter. External surface was smooth. Cut surface showed a fairly well circumscribed mass, which was yellowish orange, solid homogeneous mass, measuring 3.5 into 2.7 into 2.5 centimeters, surrounded by edematous ovarian parenchyma. This was the scanner view of the neoplasm, which shows the ovarian stroma along with a circumscribed neoplasm arranged in sheets. It's a hyper view showing the neoplasm arranged in diffuse sheets separated by scant fibrous stroma. So the neoplasm is composed of large round to polygonal cells with moderate to abundant eosinophilic to clear cytoplasm. And the nucleus is centrally placed round to oval with prominent nucleoli. So this is again an hyper view showing the cells which have clear vacuolated cytoplasm. So PA stain was done. So here it was negative, showing that the accumulated substance is not glycogen. IHC was done for calretinin, which showed diffuse cytoplasmic positivity. And inhibin also showed diffuse cytoplasmic positivity in 80 to 90% of the cells. So with this, the diagnosis of steroid cell tumor, not otherwise specified, was made. So this is a straightforward case and presented only for the rarity. So steroid cell tumor NOS forms up less than 0.1% of the ovarian tumors. The age group can vary from 2 years to 8 years, but the mean age is around 43 years. And most of them are associated with androgenic changes resulting in virilization. So 56 to 77% presented androgenic changes. So estrogen secretion can be seen in 6 to 23% of the tumors. And rarely 6 to 10% of the tumors can secrete cortisol and may present with Cushing syndrome. And bilaterality is seen in about 6% of the tumors. The chance of malignancy in steroid cell tumors is around 25 to 43%. And the features associated with malignancy are mitosis more than 2 mitosis per 10 hyper field, presence of necrosis, presence of hemorrhage, size more than or equal to 7 centimeters, and grade 2 or grade 3 nuclear atypia. So all these features if present should implicate malignant prognosis. So coming to the differential diagnosis, there are a host of tumors which form differential diagnosis for this steroid cell tumor. However, there is one non-neoplastic condition also which should be remembered, which is the pregnancy luteoma. So histopathologically, pregnancy luteoma, it's impossible to differentiate from the steroid cell tumor. But clinically, if we see, it presents during the pregnancy, and it's mostly bilateral and multiple in presentation. And cells contain eosinophilic cytoplasm more than the clear vacuolated cytoplasm which is seen in steroid cell tumor, because there is no lipid accumulation in pregnancy luteomas. And mitotic figures also increase in pregnancy luteomas. Around 2 to 3 per 10 hyper field mitotic figures are seen. So coming to the tumors which form the differential diagnosis, the closely related tumors are the stromal luteomas and the Leydig cell tumor. So stromal luteomas were given as a separate entity till the 2014 WHO classification. So after that, this has been merged into steroid cell tumor NOS type itself. But however, the pathologists may prefer to use the term pregnancy luteoma for tumors of size less than 3 centimeter, which are present in the ovarian stroma. They is usually present in the old age and are associated with estrogenic changes rather than androgenic changes. Next one is the Leydig cell tumor. So Leydig cell tumor, 2 types are there, hilar type and the non-hilar type. So hilar type have the origin from hilar cells, whereas the non-hilar types are believed to originate from the Leydig cells present within the ovarian stroma. So these Leydig cell tumors have peculiar morphological features like nesting of the cells along with a few nuclear-free zones, and also fibrinoid necrosis of the medium-sized blood vessels are seen within the tumor tissue. And these tumors are associated with non-medulated nerve fibers. And the most important characteristic of the tumor is the presence of the Reinke crystals, which is seen in about 35 to 40% of the tumors. Since only 35 to 40% of the tumors are diagnosed by the presence of Reinke crystals in light microscopy, so other tumors which do not show Reinke crystals are classified only under this NOS type. Then we have the extensively luteinized granulosa cell tumors and the thecomas. So both of these, in both of these tumors, we have to search for non-utilized cells and for the specific patterns and cytologic features. And in thecoma, there will be abundant reticulum will be present, which can also aid in the diagnosis. Next one is the lipid-rich Sertoli cell tumor. So here again, we have to search for the pattern of the tumor, which is a solid tubular pattern. And this again, it's a estrogen secreting tumor. Next one is the oxyphilic struma ovariae, which arises as a part of a component of a teratoma. So in this, we can see the other components of the teratoma. And along with that, thyroid follicles can be made out with colloid secretions, and IHC thyroglobulin will confirm the diagnosis. Next one is the oxyphilic clear cell and endometrioid carcinomas. So both of these will have epithelial pattern along with the glandular lumens. And clear cell carcinoma, we can also see the hobnail cells and the clear cells which contain glycogen. Next one is the hepatoid yolk sac tumor. So again, this can be diagnosed by the varied patterns like the Schiller-Duell bodies and microcystic pattern. And IHC of alpha fetoprotein will confirm the diagnosis. So these are the other rare differential diagnosis. Pituitary type tumors which can arise as part of the teratomas from the wall of a dermoid cyst. So this is also very rare and it is very difficult to differentiate. These tumors usually secrete ACTH, and so IHC for ACTH can aid in the diagnosis. One more rare tumor is paraganglioma arising from the ovary. So here again, it is very difficult to differentiate, except for the IHC. Chromogranin will show strong positivity. Then metastatic RCC. So this again comes as a very important differential diagnosis. Here, since it's a carcinoma, again we can make out the patterns, the glandular pattern, tubular pattern, or papillary pattern. And here again, the cytoplasm will contain glycogen instead of the lipid. And then metastasis from adrenocortical carcinoma. So this is a very remote possibility only, but anyway, this should also be borne in mind. And finally, we have malignant melanoma. So either primary or secondary. So mostly amelanotic melanomas will form a very important differential diagnosis for the steroid cell tumors. And pigmented pigmented melanomas can also form a differential diagnosis because the pigment can be mistaken for the lipochrome pigment, which is commonly seen in the steroid cell tumors. Thank you, madam.
Thank you, Dr. Anita. Thank you. And I just wanted to know the clinical presentation of this case. How did the patient present?
Madam, patient had virilizing features, madam. Hirsutism, secondary amenorrhea was present, madam.
Okay, so actually surgery is the mainstay of treatment for these kind of tumors. So
Yes,
what
ma'am.
happened? Did you follow up the patient? What happened after surgery? Did she think of the symptoms or?
Madam, surgery was done only 2 weeks back, madam. We'll follow up, madam.
Okay.
Yes, madam.
Generally good, Valer. I have reported one steroid cell tumor.
Yes,
The
ma'am.
patient is doing well.
Yes, because actually, if there is absent menses, all the menstruation resumes. Everything it falls back to normal after the removal of the steroids. So just I wanted to know how is the patient doing now?
Yes, madam.
Yes.
We'll surely follow up, madam.
Okay, thank you, Dr. Anita. Can
Malignant
we go on
tumors
to
will
the
be larger, Valer. This one is very smaller one.
Okay.
Malignancy will be larger tumor.
Thank you, ma'am. Thank you, Dr. Anita. Let's go on to the next presentation. Dr. Saravana Kumar from Stanley Medical College.
Good afternoon, all. I am Dr. Saravana Kumar from Stanley Medical College. First, I want to thank my professors, HOD, and all faculty members and pathology association members and office bearers for giving me this opportunity to present it. Today, I want to present a case from gynec pathology. So, the details of this patient.
The other participants, kindly mute your mic, please. It's so disturbing.
So the case details. This is a 50 years female who had a complaints of postmenopausal bleeding. Ultrasound abdomen was done. In that, endometrial thickness was given as 5 millimeter with features of adenomyosis was given. So endometrial biopsy sample was sent, but that was not representative. It showed only endocervical tissue. They proceeded with transabdominal hysterectomy with bilateral salpingoophorectomy. This is the cross feature. So uterus with cervix measuring 8 18 to 4 into 4 centimeter with attached bilateral ovaries and tubes. Cut section endometrium shows a gray-white lesion which is measuring about 1.8 into 1 into 1 centimeter. We have processed the entire material. So this is a microscopic picture which showed the lesion, that tumor which is infiltrating neoplasm, which is of glandular architecture, and somewhere it is showing the budding features also been seen. So this is hyperview, which shows back-to-back arrangement of glands with the lumina shows normal regular lumina with pseudo stratification of the nuclei with rounding of nuclei, which was shown, which representative of endometrioid component. So focally 10% area showed this papillary-like areas which have slender papillae with central fibrovascular core. In hyperview, which shows the slit-like lumen with the luminal irregularity was shown with the high-grade nuclear features were seen with focally budding was noted. So two components were present in this. One is major endometrioid and minor component is serous. So this pseudomatous calcification along with lymphocytic infiltration and multinucleated cells, which representative of granuloma, was also noted. So we did immunostain for this case. So ER was done. So it showed 90% is the area that glandular lesion which showed positive for ER. So the remaining 10% area which showed strong positive for P16. This slide shows the same area which positive for ER, the negative area which taken the P16. So with this we concluded this as mixed cell carcinoma, that is endometrioid carcinoma 90% and serous is 10%. We have signed out report like this. So what is the importance of this mixed carcinoma of uterine corpus? This is the WHO which says when we can diagnose the mixed carcinoma. Mixed means two or more discrete histological types has to be there, and the second component has to be either serous or clear cell, that has to be there. So this is the diagnostic criteria which is taken from WHO. So essentially two components, and also we have to exclude dedifferentiated carcinoma and carcinosarcoma. So desirably we have to confirm it with IHC. So it also says that most commonest combination in mixed cell carcinoma will be endometrioid and serous carcinoma. It has given statistics about 10% of the carcinomas are mixed among the all endometrial carcinomas. So this is taken from CAP, which says how much percentage has to be there to call it as mixed. That second component has to be there, at least 5% has to be there. Then only we can call it as mixed cell carcinomas. So what is the importance of diagnosing second component? So this is taken from Novak's, and it says if we are diagnosing a serous as second component, that may behave like a pure serous carcinoma. So that is why it is very important. So because the endometrioid, low grade endometrioid will have very good prognosis, whereas even 5% of the serous as second component, which will behave like a primary serous, that is prognosis will vary. So this article from the American Journal of Surgical Pathology, which is molecular analysis of mixed carcinomas, endometrial carcinomas. They have taken 18 cases of both serous and clear cell as secondary component. So they did next generation sequencing and IHC for all these cases. So 16 out of 18 cases shows molecular clonality, the same molecular origin was there. So this is one more article which will give emphasis on the diagnosis of serous carcinoma. What are the difficulties will occur? So here also they have mentioned 5% of the second component has to be there, either serous or clear cell component. So even here they mentioned as even as little as 10% of the type 2 component would adversely affect the patient's outcome. That is very important. In our case also, we have detected as 10% serous component in the mixed endometrial carcinoma. So the diagnosis has to be paralleled with IHC or molecular tools. So what are the difficulties may arise in the diagnosing of second component as serous? So high-grade endometrioid can mimic the serous carcinoma. So these are the H&E features has to be there to tell the test definitely serous. First thing is the papillary feature. That papillae should have the slender lumina has to be there, and luminal irregularity has to be there. All high-grade new features. And one more, the budding will be there in the serous carcinoma. Whereas in the high-grade endometrioid may show below glandular features that there will not be any budding or that luminal irregularities. So we did P16 for this case. Why P16 is more appropriate on this case? In this study, which showed that P16 will be positive for 90 to 100%, which will show diffuse and strong positivity in the serous carcinomas. So this is very appropriate study, which will justify our IHC marker. So what are the prognosis for diagnosing a second component? So this study shows they did a study with they compared the mixed endometrial carcinoma with the pure endometrioid and pure serous carcinoma. They have taken 22 cases of mixed, which include serous and clear cell as second component. They have compared it with endometrioid, pure endometrioid and pure serous and clear cell carcinomas. They have followed these cases for almost 5 to 6 years. In that, they have detected that the second component as serous or clear cell will adversely affect the prognosis. So that is why it is very important to diagnose a very minute amount, that is very minimal. Even 5% of the serous can behave like primary serous carcinoma. So that is the point we want to emphasize in this from this case. Thank you, ma'am.
Doctor, what do you mean by minor serous component? Is there any cutoff point or any percentage which has been described?
Ma'am, 5%. They are saying in WHO also CAP clearly says 5%, ma'am.
Okay, what was the percentage in your case?
In our case, it is 10%, ma'am.
So that means it is not minor, right?
No, ma'am, it is minor only, ma'am. Minimum 5% has to be there to diagnose it as second component. Here,
ma'am, I think he's right, because majority is the other type now, ma'am.
Yeah, that is true. That I agree. That I agree. So because we have to go by the majority and classify according to the major component. So that is okay. Okay.
Correct, ma'am. So the minor component, if it is more than certain percentage, it is worthy of mentioning in the report because it has a bad prognosis. Is the
no, I just wanted to know. I joined late, so I wanted to know what is the cutoff and what is the percentage. Okay.
Understood.
Even ma'am, one second, ma'am. Even in this study, the second component they have taken as from 5 to 30%, ma'am. They consider from 5 to 30% as second component in this study.
Oh.
In that adverse prognosis was there.
Ma'am, the study shown on the screen on the line.
Yes, ma'am. Here in this 5 to 30%, they have taken that.
The line, madam. Minor components are arbitrarily defined anywhere between 5 and 30%.
30%, yeah. Okay. So and another question: does it alter the stage if we go staging?
Yes, ma'am. It is high grade, ma'am. So usually endometrioid we will type grade 1 and grade 2, ma'am. So definitely serous means it is adversely affect the prognosis. It will behave like a primary serous carcinoma. If the second component is more than 5% serous means it will behave like a primary serous carcinoma. That is from the Novaks, ma'am. They are clearly telling. So mixed behave as aggressively as pure serous carcinomas. The cutoff is also given as 5% serous features.
So even if 5% is present, it means aggressivity, ma'am.
No, does the myometrial invasion alter anything? Because see, according to the protocol, we classify mainly because of the less than 50% or more than 50%, right?
Yes, ma'am.
Now in this case, does it alter?
Actually, serous carcinoma without less than half of the myometrium also invade lymphatic
it's
and
aggressive.
abdominal.
Yeah.
Yes, ma'am.
Okay.
It is aggressive in that way.
Yeah. No, what is you have written it as stage 1?
No, ma'am.
Or
This
was it
given
maybe
as
the
grade
reference?
2, ma'am. Grade 2, ma'am.
Grade 2. What is your FIGO stage?
FIGO 1A, ma'am.
Okay.
Ma'am, one more question. See, as you rightly said, no, serous carcinomas are supposed to be upstaged, even if the myometrial invasion is less than 50%.
That is what I wanted to know.
Yes.
That is what I wanted to know.
Yes, ma'am.
Yeah.
So mixed carcinomas, no, doctor, the question is mixed carcinomas, do you upstage them also? Because the percentage of minor component, no, you said is between 5 to 30%.
30,
so is it justified to upstage a mixed carcinoma also, like in case of a serous carcinoma? I think that is the question.
Yeah.
Yeah,
Yes.
Do we upstage it? Is there any like recommendation for that?
Upstaging in WHO it is given as based on the nuclear features, ma'am. Nuclear pleomorphism they are upgrading. So in
No.
No, I'm
See,
sorry. No, I'm sorry. It is not correct. What he says is not correct.
Yeah, correct only. See, no, doctor, there is another staging which has come up after the 8th edition AJCC. There is a recent staging for endometrial carcinomas depending on the aggressiveness of the histology. Okay.
Yes.
That is what madam is asking. So, if it is serous carcinoma, it is called aggressive histology.
Yes.
Prior to this, no, in 8th edition staging, there was no like mention about the aggressive histology. Based on that, upstaging was not done in 8th edition. But now in the current edition, upstaging is done if it is an aggressive histology. So serous carcinoma is an aggressive histology. Yes, likewise, mixed carcinoma also, does it come under aggressive histology? And does that warrant an upstaging of the tumor? Is the question which we will all go and refer possibly. Probably we don't know.
No, I think your question is quite valid, Chandra, because see the presence of serous itself is always an aggressive. So I think whether irrespective and less than 5%, you don't mention. If it is between 5 and 30, I'm sure we have to upstage the lesion because of the serous component, which has clinically aggressive behavior. I think we will have to definitely upstage. I think any oncologist will be definitely able to guide us better.
Ma'am, from what I can't quote the reference now, but what when seeing this case, like Dr. Ajay has reported this case, but we all saw the slides.
Under aggressive
yeah, even for mixed tumors, you have to upgrade it. That is what. That is what.
That is what I also felt.
Because the component, even if it's a minor, it is very valid, and even if it's a mixed tumor, we have to upgrade it. That is
I think that's correct.
I've come
up.
Yes, ma'am.
Yes, thank you, doctor. Because of you, I don't think we are going to forget this mixed carcinoma and the fact that we have to upstage the tumor and put it under aggressive histology. It was a very good one.
Thank you. Thank you so much for the. Thank you, Sita ma'am and Chandra ma'am, and thank you, Dr. Saravanakumar.
Thank you.
Thank you all the presenters. And it was Dr. Ajay from Stanley who reported this case, and thank you, Dr. Ajay. Okay. Can we go on to the next presenter, Dr. Sweta Narla from Apollo? Can you share your screen, Dr. Sweta? Dr. Sweta?
Hello, ma'am.
Oh, Dr. Revati, yeah, you're ready? Please,
yes, ma'am, ready, ma'am.
Start sharing, please.
Okay, ma'am. Very good afternoon, all. I thank my professor, Dr. Chandra, ma'am, for giving an opportunity to present a case in this forum. So, coming to case detail, so our case is a 53-year-old female.
Revati, just hold on, pa.
Yes, ma'am.
Something wrong with the it's you're presenting from your mobile?
Yes, ma'am.
Oh my God. Revati.
Ma'am.
Okay.
No.
Okay. Okay, ma. Okay, now it's fine, ma. Now it's fine. Continue,
okay.
ma.
I'm a 53-year-old female who is a postmenopausal woman for past 8 years. She presented with complaint of postmenopausal bleeding on and off for past 1 year, ma'am. On admission, there was only one positive past history of diabetes mellitus, and there is no other risk factor of any heart disease or hypertension in this patient. And on routine investigation, all her hemogram and biochemical markers were normal. Our serum markers, CA125 was 12.9, CEA was 2.10, beta HCG was 0.05, LDH 171, AFP was 1.96. So all these serum markers are also within normal range. And the MRI showed a 4.5 by 4.4 by 4.4 centimeter solid and cystic lesion in the right adnexa with solid and papillary components. The patient was taken up for staging laparotomy, and we received a total abdominal hysterectomy with bilateral tubes and ovaries. So this is an hysterectomy specimen where endometrial cavity was normal, and on the right side, both the ovaries and one tube appeared normal. And this is a mass which was received separately in the same container. And external surface, the mass was, there was a tubal-like femoral end was seen attached to the mass, and the mass size was 5 by 4 centimeter, with cut surface showing solid yellowish and papillary components. On microscopy, endometrium, there was showed only proliferative phase, myometrium, adenomyosis, cervix, chronic cervicitis, both ovaries and one tube. There was no evidence of any tumor invasion. And this, the solid mass, this is the tubal epithelium, femoral end of the tube, and the underlying mucosa showed a well-differentiated neoplasm arranged in glands and papillae and slit-like, showing a few slit-like spaces. And this is a picture showing glandular pattern and some cribriform pattern also seen. On higher power, so the gland were columnar cells with nuclear stratification ATP, and mitosis were 2 to 3 mitosis per hyperfield, and there were minimal mild to moderate ATP was seen in the entire section. And there is no evidence of invasion into adjacent ovary or tube or endometrial cavity. So with these features, since there is no tumor in the endometrium, we reported, and the morphological features were similar to the endometrioid adenocarcinoma, we gave as endometrioid adenocarcinoma arising from fallopian tube, and it is FIGO stage 1A. Coming to the discussion, so this endometrioid adenocarcinoma is the second most common tumor arising in tube with incidence of 22%, followed by serous carcinomas, and they are very rare in comprising only 0.3% of all female genital tract tumors. And these endometrioid adenocarcinoma usually occur in postmenopausal women as a unilateral mass, and most common site is distal end of fallopian tube. Our case is also a postmenopausal woman, and only the femoral end of the tumor showed a mass, and it is an unilateral mass. Like endometrial tumor arising in uterus, these tumors also have a precursor lesion, which is known as tubal endometrial intraepithelial lesion or atypical hyperplasia. On gross, they usually present as a friable yellow mass with a mean size of 0.4 to 6 centimeter. And microscopically, they have a solid glandular spindle cells with variable squamous differentiation. And immunohistochemistry, mostly these tumors are WT1 negative, and P53, they usually show wild type staining. And the most common treatment is surgery, where they usually do a staging laparotomy. And prognosis is usually related to clinical stage. Mostly these are all early stage tumor, and they have a good prognosis. The 5-year survival rate is 77% in almost all cases of endometrioid adenocarcinoma in fallopian tube. The most common differential diagnosis is you have to differentiate whether it is any secondary arising from endometrium or ovary. In our case, there was no growth in endometrium or ovary. So it is a purely tumor arising from tube. And the second common DD is these tumors have similar morphology compared to female adnexal tumor of Wolffian origin, where both tumors will have a sieve-like, slit-like spaces filled with some secretion. In endometrioid carcinoma, they are mostly columnar cells, and they have a intraluminal mucin secretion, and the glands will have a polarized, the cells will be polarized towards the lumen. Whereas in FATO, the secretion will be colloid-like secretion with PAS positive. PAS positivity will be seen, and the nuclei will be polarized away from the lumen. And the site is endometrioid usually occur in the distal end of fallopian tube, whereas FATO will occur. Most common site is broad ligament, and less commonly they can arise in mesonephros of fallopian tube and ovary. And IHC wise, endometrioid carcinoma will be WT1 negative, whereas FATO will be WT1 positive. And this is P53 negative, whereas FATO P53 wild type, whereas FATO is P53 negative. This is the most common differential diagnosis. These are my references, and thank you, ma'am.
Doctor,
Yes, ma'am.
Yeah, you have given it as a cyst, no, adnexal cyst. The Wolffian origin was
Most common DD, ma'am.
அதான் இல்ல நீங்க ஃபர்ஸ்ட் வாட் எவர் த பிக்சர் யூ புட் இன் த மீட்டுக்கு போட்டிங்க இல்ல.
Yes, ma'am.
That one was showed a very few tubules. இது ஒரு cyst வேற adnexal cyst, so I thought of a
இல்ல மேம் டியூப் மேம் அது போர்ஷன் ஆஃப் டியூப் போட்டுருப்பா.
அந்த டியூமரும்
இல்ல சந்திரா.
மேம்
அந்த இதுல வந்து ஒரு சிஸ்டிக் இதோ this area there was something like a cyst, no, there was something like a cystic lesion அங்க அந்த செக்ஷன் ஒண்ணும் வரலையே. ரெண்டாவது have you proved it is of tubal origin?
Ma'am,
you have taken enough sections?
Yes ma'am, it was arising from the tube. Tubeல தான் மாசே இருந்துச்சு மேம்.
இல்ல இதுல endometriumல sections நிறைய. Did you rule out a primary endometrial tumor by many sections?
Yes ma'am. Yes ma'am.
Endometrium.
Ma'am, this is only this area, ma'am. The cyst wall, it is fallopian tube lining. That cyst only is this picture, ma'am. We took bits from that area also.
Yeah, but the tumor seems to be outside. It is not arising from the wall. It is not arising from the tubal mucosa.
Tubal lining la irundhu varala.
அதுதான் நான் சொல்ல வரேன்.
எனக்கு என்னமோ ஓவரியில இருக்கிற உல்ஃபியன் டியூமர் தான் நான் என்னோட ஃபர்ஸ்ட்.
ஐயோ மேம், அது actually gross tube was distended and came, actually resected and came. Ovary was normal.
You have seen the full tumor. When you are sending the picture, you are not giving all the findings இல்ல.
இல்லப்பா, டியூபர்ல இருந்து ஆரிஜின் வந்து நீங்க அசர்டைன் பண்ணிட்டீங்களா? That is my question.
பண்ணிட்டோம் மேம், 100% பண்ணிட்டோம், because it was inside the lumen. And the orientation, I think, sorry for the pictures, that is, I think, a little confusing. The mucosa appears as if it is outside. You are right, நீங்க சொல்றது கரெக்ட் தான் மேம்.
ரேரிட்டியா போட்டுருப்பீங்கன்னு தான் நான் நினைச்சேன்.
சரி, okay, I take your word, Chandra.
Yes ma'am, thank you ma'am.
Thank you ma'am.
Thank you, Dr. Revati, and thank you, Chandra madam. And can we go on to the next presentation? Dr. Sweta from Apollo Cancer Center. Dr. Sweta, are you ready? Dr. Sweta, are you there?
She's not answering.
Yeah,
ma'am, I'm there, ma'am.
I saw her in the button.
Okay.
Shweta, please share your screen. We have.
Okay, yeah, ma'am. I'm sharing.
Yeah.
Ma'am, is my screen visible?
Yeah, Dr. Shweta. Yes, fine. You're audible and your screen is visible. You can start.
Okay, ma'am. Good afternoon, one and all. So today's one interesting case of an enigmatic lesion of ventricle, that is a brain lesion. This I'm presenting, actually, it's a new entity which has been recently introduced in the WHO 2021 of central nervous system. So this is actually a case of a 15-year-old boy who had presented with history of headache, vomiting, and blurring of vision. Imaging showed a temporal solid cystic lesion. So they had taken the boy for surgery. Intraoperative findings, lesion was extending from the temporal horn of the left lateral ventricle with attachment to the overlying dura. So they went ahead with gross total excision of the lesion, which was gray tan to gray white. It was solid cystic, measuring around 6 centimeters in maximum dimension. So when the sections were taken from the lesion, this was the picture. As we can see, it is a very infiltrative, very cellular blue tumor with numerous congested blood vessels and multiple patchy foci of necrosis is visible. So again, in this picture, very cellular blue-looking tumor with numerous congested blood vessels and multiple foci of necrosis. So on high power view, as we can see, these cells, they are arranged in the form of a sheeted pattern, infiltrative, very scant cytoplasm with an enlarged, round, relatively monomorphic or a little like a very embryonal look to the tumor. And there are some areas where the tumor cells were present around the blood vessels, not exactly like a true rosette, but somewhat like a pseudo rosettes. And there were numerous mitotic figures, which is visible in the screen. In addition, apart from these monomorphic, very undifferentiated tumor cells, there are some areas or some cells, in fact, which is depicted with the arrow, which had more cytoplasm compared to the other cells, which had relatively less cytoplasm, not exactly rhabdoid, but a little more cytoplasm compared to the other cells, which were very few in number. So with this morphology, we thought of a high-grade malignant tumor for sure, with a differentials of high-grade glioma, that is glioblastoma, in view of some rosetoid areas, probably a grade 3 ependymoma. Medulloblastoma, again in view of an very embryonal tumor, very blue looking with some pseudo rosettes, medulloblastoma, and in view of some cells which had occasional rhabdoid morphology, atypical teratoid rhabdoid tumor. So with this differentials, we went ahead with immunohistochemistry, a basic GFAP, a glial marker, which was positive in many areas, diffuse positive. But in some areas, the staining was relatively less. In fact, it was patchy staining. So to put things together, some areas showed diffuse GFAP positivity, whereas some areas showed a variable GFAP positivity. So with this kind of GFAP positivity, a medulloblastoma is completely excluded. So the other glial marker is OLIC2. OLIC2 was completely negative in all the areas. So it is a glioma. To rule out ependymoma, we did ependymal markers like EMA and D240. Both were negative. Typically in ependymoma, EMA and D240 presents as perinuclear dot-like positivity, which is seen in the picture as shown here. But in our case, both EMA and D240 were completely negative, so it ruled out an ependymoma. So ependymoma was excluded. Then since ATRT was our differential, we did INI1. INI1 showed retained positivity. So retained positivity is taken as negative feature for ATRT. So in ATRT, there will be loss of expression of INR1. So in this picture, there is a blood vessel in the center where the endothelial cells are taken as the internal control and the tumor cells should be negative. But in our case, INI was retained, so ATRT was excluded. Since it was a young pediatric age group, even though it was not midline, since it was a high-grade glioma, we did markers to rule out a diffuse midline glioma, that is H3K27M and H3K27ME3. In our case, H3K27M was negative and ME3 was positive, that is retained. So this excluded a diffuse midline glioma. To call it a diffuse midline glioma, this should be the staining pattern. That is, H3K27M should be positive and H3K27ME3 should be negative. So both these go hand in hand. There should be positivity of H3K27M and there should be loss of H3K27ME3 to call it as a diffuse midline glioma. When it is reversed or when only one of them is positive and the other is negative, we should not call it as a diffuse midline glioma. So in our case, it was negative. So diffuse midline glioma was excluded. So to complete the panel of glioma, we went ahead with ATRX, where only internal cells, that is internal control cells, are positive. The tumor cells are completely negative. IDH1R132H was completely negative. P53 showed positivity. Ki67 proliferation index was very high. So what was the diagnosis? So it was a high-grade glioma, pediatric age group, the presence of GFAP variable staining, OLIC2 negativity, ATRX loss, high Ki67 proliferation index, P53 positivity. So this was a diagnosis. Diffuse hemispheric glioma, H3G34 mutant, CNS WHO grade 4. But we didn't have an antibody to prove that it is G34 mutant. So we had sent it to NIMHANS where they had done IHC and it came out to be G34R positive and G34 negative. So finally we concluded it as a diffuse hemispheric glioma, H3G34R mutant, CNS WHO grade 4. So why this entity is important is, if we see the previous WHO 2016, there was no mention about this entity anywhere. Probably it would have been diagnosed as a glioblastoma IDH1 mutant. Whereas the WHO 2021, under the heading of pediatric diffuse high-grade gliomas, there are 4 entities, out of which H3G34 mutant glioma is one of the entities. So this comes under the 22 new entities which have been included in 2021 new WHO. The reason for presenting this is because these are very uncommon tumors, very, very rare tumors, hardly 1 or 2 cases we get per year, but it should not be missed. So that is the reason to present this case today. And it's a new entity for all of us, and we are also still in the stage of learning it. And the presence of GFAP variable positivity, OLIC2 negativity, ATRX loss, IDH1 negative immunostaining should give us a clue that this could be G34 mutant diffuse hemispheric glioma, especially in a pediatric age group. So a few points about this entity. It is an infiltrative glioma with a mutation occurring in H3.3A gene. Due to the mutation, there is a change of amino acid replacement from glycine to arginine or from glycine to valine. This is most common in the cerebral hemispheres, with spread to the midline structures and leptomeningeal dissemination. The clinical features are usually seen according to the anatomical structures involved. MRI is not much helpful because it will be similar to any other high-grade non-midline glioma. There can be contrast enhancement with mass effect. What is important to note is there can be leptomeningeal dissemination, necrosis, cystic change, hemorrhage, or calcification. It is usually seen in adolescent and young adults with a median age of 15 to 19 years. Our case was 19 years boy with a slightly male predominance, no known risk factors. The pathogenesis is attributed to the missense mutation involving the tail of histone protein H3.3, due to which there is upregulation of the proto-oncogene NMYC. Coming to the histopathological features, it will be typical like a glioblastoma-like pattern, very cellular, blue-looking tumor with brisk mitotic activity and infiltrative pattern. Microvascular proliferation and or necrosis can be seen. There can be other alternative patterns as shown in this picture. It will look like a typical CNS embryonal tumor where medulloblastoma, ATRT, and high-grade ependymoma, as was there in our case, will be the differential diagnosis which needs to be excluded. So when we did literature search, since it was a new tumor, not many cases have been described. There are case reports where a pediatric diffuse hemispheric glioma with gain of BRAF locus was described, where the different histological patterns they have noted. There can be somewhat like a rosetoid pattern, very embryonal looking pattern, very pleomorphic, which will look just like a GBM. So to put things together, it can have either a GBM pattern, it can look like an embryonal tumor, or some kind of rosettes. So immunophenotype, positivity for MAP2, FOXG1, typical loss of ATRX, positivity for P53, negativity for OLIC2, variable GFAP expression, and high Ki67 proliferation index. So the clinch for the diagnosis is positive immunostaining for either G34R or G34V. Both of these are nuclear positive immunostains. By default, these are CNS WHO grade 4 tumors. This is another paper where they have studied the immunohistochemistry pattern of H3G34 mutant diffuse gliomas, where the morphology can be any morphology, where it can be either looking like an embryonal tumor or a GBM-like pattern. But in most of the cases, OLIC2 was negative, except in case B, where there was patchy OLIC2 positivity. P53 was positive and high in all the cells. ATRX was lost in all the cases except in B, there was retained ATRX expression. So to continue, the diagnostic molecular pathological features, most of them show P53 mutation and loss of ATRX gene. It is mutually exclusive with IDH1 or IDH2 and H3K27M as was seen in our case. This G34R and G34 mutations, there is no differences between the prognosis, the morphology and the IHC pattern, except that if it is G34R mutation, the IHC pattern will be positive for G34R and negative for G34V and vice versa. So these cases, they have a very poor prognosis with a median progression-free survival of 9 months and a median overall survival of 18 to 22 months. Ours was a very recent case diagnosed just last month. So we are yet to know what is the prognosis of this patient. They have mainly local recurrences, MGMT methylation and absence of oncogene amplifications have shown to have a longer overall survival. But overall, since it is a grade 4 tumor, they behave very bad. Yeah, thank you so much. Thank you, ma'am, for giving this opportunity. So this case mainly I have presented just to say that it's a new entity which has been included in the new WHO 2021 of CNS tumors. And the morphology will look just like a GBM. And the IHC pattern will give us a clue for the diagnosis.
Yeah, very nice case. Very, very inspiring, I should say, because you have done a complete work. My only doubt is,
yes, ma'am.
Why hemispheric? Why don't it be just a diffuse glioma, H3, G3, 34 mutant, etc., etc., etc.? Why hemispheric?
This I don't know, ma'am. This entity, why they have called it hemispheric, I really don't know.
I wonder why. Is it because it is occupying half or something like that? Hemi part of it or a spheric? I don't know. The thing is, see, maybe we would have called it when we do not have all this mutation and all that. Maybe we would have called it a diffuse glioma high grade
or a GBM, IDH
that
mutant
is what
GBM.
we would have called it like that. No, when we do not have all these facilities. Any monoclonal antibodies available for the treatment since there is a lot of mutation here?
No, ma'am.
No
Actually,
idea.
they behave very poor. Hardly. It's a new entity, so it's just evolving. The treatment options are very minimal. Even though there is gross complete resection, they say the prognosis is very bad and less than 1 to 2 years.
I know, but are they following it up with some kind of a chemo or something like that?
Yeah, this patient actually came for follow-up this month. They have advised for radiation. So they have not come back later. It was a very recent case. Last month only I had diagnosed it.
Okay. Ayo, 15 years. My God.
Yes, ma'am.
Okay, thank you. Nice. Very nice.
Thank you. Thank you so much, ma'am.
Thank you. Thank you, Shweta, for that highlighting that embryonal tumor with all the panel of markers. And it was really a good take-home message today.
Thank you, ma'am.
Thank you. I just wanted to know, was these kind of high-grade gliomas are associated with Lee-Fraumeni syndrome? Like the boy, what about this boy?
No, ma'am, they have not described any syndromic association. Actually, the etiology, they don't know why it occurs in young age group. There is no risk factors, no syndromic association as such, but like other tumors of pediatric high-grade gliomas where there is diffuse midline glioma, even such cases also, there is no syndromic association as such.
Very aggressive tumor by state.
Is there any hereditary association of this tumor? Because in Lee-Fraumeni syndrome, again, there is a hereditary association. That's why.
No, ma'am, no syndromic or autosomal dominant or anything.
No, if this kid had any family history of...
Nothing. First case, index case, ma'am.
Okay. Thank you.
In marriage, any consanguinity in marriage? Parents?
That
no idea.
part we don't know, ma'am.
No, why I asked you hemisphere is, there is another entity by pediatric, your classification says midline glioma. So that is the first grade, you mentioned that. And second one was it hemispheric.
Yes,
so whether This adjective,
Yes, ma'am.
does it connote anything? I just wanted to know. Just curious. Nothing else.
Ma'am, like you said only, ma'am. Like how you said, no, pediatric gliomas, I think, are classified into midline and hemispherical. So probably one is midline with a different type of mutation, and the hemispherical shows a different type of mutation.
that could be. Yes,
It's only the mutation.
Probably that
Okay.
could be the reason.
Yeah, that could be. Even though midline gliomas, they have mentioned it at midline, but actually we had done one study in that out of from 2000, I think 17 till now, we got around 30 cases. In that, 2 cases were not midline.
Yeah,
So
yeah, that
even
also
though
has
it
been
was,
reported. Yes,
yeah,
yes.
few
In
cases
the WHO
are,
also he mentions. Yes.
yeah, few cases are not midline, even though it is H3K27
Mm.
altered.
Correct.
Okay.
Ma'am, just for the information, we have a message from one of our participants, Dr. Nufina. She says the tumor involves the cerebral hemispheres exclusively, and it can spread to the midline structures. That's what Dr. Nufina says.
No, so in this case,
so that's why the answer for Sita ma'am's question.
Okay, but then in this case also, I think Dr. Shweta highlighted that type of presentation. Like from the hemisphere, the child also had a spread to the midline.
So that's why the name.
I mean, I think
the name.
Maybe.
Yes, ma'am. Good evening, ma'am.
Thank you.
Can you?
Thank you for the information. Thank you.
Okay.
Good evening, ma'am. Are you able to hear me?
Yeah.
Yes.
Ma'am, this is Anfina here. So the epicenter of this tumor is actually in the cerebral hemisphere, the diffuse hemispheric glioma. It can then spread to midline, probably because of its aggressive nature. So these kind of tumors, since they originate in the hemispheres and have this particular specific mutation, they have been named as H3G34 mutant diffuse hemispheric glioma. And they show a very, very aggressive behavior.
Thank you.
Okay. Thank you, Dr. Nufina. Thank you so much. So can we go on? And thank you, Dr. Shweta. And can we go on to the next presenter, Dr. Femila from Chettinad.
Good afternoon, ma'am.
Yeah, good afternoon. Please share your screen.
Good afternoon, all senior pathologists and whoever is present in the meeting and presenting in the meeting. Very good afternoon. I thank TNPC IAPM office bearers and head of our department, Dr. Vijayashree ma'am, for giving me this opportunity. Is my screen visible?
Yeah, Dr. Femila, yes.
Yes, I go for slideshow. My internet is unstable, so slideshow is yet to be turned on.
You will have to go for a slideshow, ma.
Yes, ma'am. My internet is slightly unstable.
Oh.
Dr. Femila, do you need some time? Can we ask the next presenter to present by the time you can come back?
Yes, ma'am. Is it visible? I mean,
yeah. Dr. Femila, you continue, please.
Yes, ma'am. Thank you so much. This is a case for which we need some discussion in cytological interpretation. As such, it is a unusual but a routine case. It can be interpreted straightforward. The case details are: the patient is a 52-year-old postmenopausal female. She presented with swelling in the right breast, and she had history of blood mixed discharge from the ulcer. There were no axillary lymph nodes and no similar family history or past history. Clinically, she had a fungating mass. Nipple was retracted and skin over the swelling was fixed to it. It showed ulceration and puckering. The tumor was fixed to the chest wall. The consistency of the swelling was hard and margins were ill-defined. Ultrasonogram showed a solid cystic lesion in the breast, which was reported as Birat's 4, and 2 subcentimetric lymph nodes were present in the right axilla. FNAC we did first, which showed predominantly sheets and clusters of there is we had these kind of cells with abundant vacuolated cytoplasm, along with some cells with eosinophilic cytoplasm. Both of them had well-defined cytoplasmic borders, and nucleoli were inconspicuous or absent. Subsequently, we received the MRM specimen, which confirmed the infiltrative nature of the tumor. There is a network glitch in the broadband. So this was the tumor, gross pathology of the tumor. So in the sections, we had a tumor which had two types of cells, two populations of cells, both with the sharply defined cell borders, one with abundant eosinophilic PAS positive diastase resistant granular cytoplasm, and the other with abundant vacuolated cytoplasm. The cells showed nuclear pleomorphism, vesicular nuclei, prominent nucleoli with brisk mitotic activity and atypical mitosis as well. The tumors are arranged in papillary, micropapillary, acinar, and tubular patterns and in solid sheets. Extensive necrosis, stromal desmoplastic reaction, acute and chronic inflammatory cells, vascular tumor emboli were also found. So no TCIS component was noted. Skin over the swelling showed a dermal infiltration by the tumor, but the nipple and areolar skin was free of tumor. 2 of the 18 right axillary lymph nodes harvested showed metastasis. Pathologically, the stage was PT3 and N1A-MX. So we did immunohistochemistry for this case. So this was ER, which was negative, and PR also was negative. HER2 showed a 3+ positivity in the tumor cells, and Ki67 was also quite high. We used multi-cytokeratin as well, which was positive, and the AR was positive in the tumor cells. So what is the most likely diagnosis? So we concluded it as invasive breast carcinoma with apocrine differentiation. So invasive carcinoma of breast with apocrine differentiation is a special subtype of breast carcinoma. The age of presentation ranges from 48 to 60 years. It is uncommon, and the incidence ranges from 0.3 to 4% of the female invasive breast carcinomas. It is seen more commonly in the middle-aged women. Its incidence is extremely rare in the male breast. It can be misdiagnosed as invasive duct carcinoma. In the WHO classification of the breast tumors, carcinoma with apocrine differentiation is recognized as a distinct entity. This case is discussed here in the City Pathologist Meet for the diagnostic challenge posed in cytological interpretation. Two types of cells will be seen in apocrine carcinoma upon FNAC smears. Type A cells have abundant eosinophilic granular cytoplasm, enlarged nuclei, prominent nucleoli, and type B cells have abundant vacuolated cytoplasm with intracytotic lipid. The type A cells are diastase resistant and PA is positive. Then apocrine differentiation occurs in invasive carcinomas, no special type also. Lobular carcinoma, tubular carcinoma, medullary carcinoma, micropapillary carcinomas, of course in DCIS and LCIS also. And focal apocrine changes can be seen in several breast lesions ranging from benign cysts to invasive carcinomas. However, we cannot suspect every other case with this diagnosis. So differential diagnosis, when we narrow down, hardly we get malignancies such as secretory carcinoma, oncocytic carcinoma, and papillary carcinoma. Sometimes we get this apocrine differentiation, and invasive duct carcinoma, apocrine DCIS. Benign breast lesions with apocrine morphology include granular cell tumor, apocrine metaplasia, histiocytic proliferation, even fibrocystic disease. If there is sampling error, then apocrine cysts, apocrine adenosis, apocrine adenoma, all these can be quite confusing. In these cases, the immunohistochemistry can help in the cases where morphological interpretation alone cannot aid in differentiating between these cases. Hence, the diagnosis of apocrine carcinoma can be challenging. However, if there is overlapping of cells, nuclear pleomorphism, high NC ratio, they are not usually seen in benign lesions with apocrine differentiation. So, in that case, we can conclude it as malignant. The diagnostic interpretation of apocrine carcinoma on cytology smears may be challenging because of its morphologic mimics. FNAC smears show large polygonal cells with abundant granular cytoplasm and sharply defined borders. The nuclei will be vesicular with irregular nuclear borders and show prominent nucleoli. Predominance of type B cells, that is vacuolated cells in cytology, that really poses a difficulty in arriving at the diagnosis, and this might be due to sampling error. In 2005, Japase et al. Proposed the criteria for diagnosing apocrine carcinoma. The first point is 75% of the tumor cells exhibiting apocrine features. Now it has been revised to 90%. And then second point, large cells with granular eosinophilic cytoplasm can be accompanying. Third point, sharply defined cell borders. Fourth, large, round, vesicular, and maybe pleomorphic nuclei. And fifth point is a low NC ratio, that is less than 1:2. So here, if we get cells with vacuolated cytoplasm in breast aspirator, we have to look for inflammatory cells or if there is any giant histiocytes. If it is present, then first we have to rule out fat necrosis or xanthogranulomatous reaction. Then if it is not present and proteinaceous material is present in the background, then we have to search for one second. We have to look into the clinical details. If the patient is very young and she is breastfeeding, then we have to think in terms of galactosile. If the patient is not breastfeeding, then still dactyctasia and fibrocystic disease can be possible. If the patient is of middle age, then mucinous carcinoma has to be ruled out. In that case, also vacuolated cells we can get. Suppose if the proteinaceous material is not present in the background, then we have to think in terms of multiple diagnosis. Patient is young and the nipple areolar complex involvement is present. There are benign ductal epithelial cells only arranged in papillary pattern. Then we have to rule out intraductal papilloma. If the cells have sharply defined cell borders, there is another population of cells with eosinophilic granular cytoplasm and they stain positive for PAS and they are diastase resistant, then it could be apocrine carcinoma. If there is PAS positive material, but in the microcystic spaces, then we have to think in terms of secretory carcinoma. If there is focal squamous merule and calcification, necrosis, and oil red bow is positive, then it could be sebaceous carcinoma. If there are atypical cells in papillary pattern, then it can be papillary carcinoma. So thinking in these lines, then how do we differentiate the morphologic mimics? Do we do ISC? First of all, with clinical details and the morphological interpretation, we have to narrow down the possibilities. After that, if we go for ISC with the cell block, then we have a clear-cut, then we will have a clear-cut conclusion. Apocrine carcinomas are usually negative for ER and PR. People, many I've heard talking like it is triple negative, but actually in the literature, it has been given that it is around 50% it will be positive for HER2. So it can either be triple negative or HER2 positive type. So there are two subtypes in this. And interestingly, it is positive for androgen receptor. Even sebaceous carcinoma is androgen receptor positive. GCDFP also is positive. GATA3 is positive. Mammoglobin is positive. CK7, 8, 18, 19, 20, all these are positive. EMA is positive. E-cadherin is positive. And BCL2 is negative. Sebaceous carcinomas will be positive for ER and PR. HER2. And sometimes it will be negative also. ER and PR may be negative also. AR is positive and adipophilin is another ISC which is positive in sebaceous carcinoma. Of course, sebaceous carcinoma is not considered as a breast carcinoma. It is a skin adnexal tumor. But in this case, the patient has a fungating tumor. It can still come under the differential diagnosis. Secretory carcinomas will be negative for ER and PR, HER2 also. EMA will be positive. Alpha lactalbumin positive. S100 is positive. E-cadherin positive. CK8, 18, all these are positive. GCDFP is also positive. Nowadays, SOX10, pan-TRK, these are also used. Papillary carcinomas, morphologically, generally, it doesn't cause problem unless it is a error, that is sampling error. So this is a ER positive, PR positive, HER2 negative. CK8 and 18 are positive. CK5/6 will be negative and CK14 also is negative. Mucinous carcinomas will be positive for ER, PR, WT1 and AR may be positive or negative. HER2 will be negative. Oncocytic carcinoma is actually not a true differential diagnosis because we will not get vacuolated cytoplasm, but we'll have a eosinophilic granular cytoplasm. So that case, the cytokeratin will be positive. ER may be positive or negative. GCDFP may be negative or positive. HER2 may be positive or negative. And the specific antibody is the anti-mitochondrial antibody, which is positive in oncocytic carcinoma. Granular cell tumor will be negative for CK. It is a benign tumor And GCDFP is negative, ER is negative, AR is also negative, CD68 is positive, S100 is positive. We can think in terms of histiocytic proliferation also. Generally, it doesn't present like a fungating mass or even as a prominent big swelling, but CD68 may be positive in that case if we think in terms of histiocytic proliferation. So to be designated as carcinoma with apocryne differentiation, the percentage of the tumor cells, what is the cutoff for calling it as carcinoma with apocryne differentiation? It is actually 90%. Originally, it was defined as 75% by Japase et al. They are not associated with the BRCA1 or 2. Actually, loss of PTEN mutation has been described, but still it is, though loss of PTEN is actually considered as familial, but still it is not associated with BRCA1 or 2. So these are my references. Actually, we can also go for genetic studies. Of course, in India, it is still questionable. Cytogenetic analysis, we can conclude apocryne carcinoma, and even we can do electron microscopy also, especially to differentiate from oncocytic carcinoma. In gene expression studies, these tumors express luminal cytokine marker as well as luminal androgen receptor. So that way we can. Next generation sequencing also loss of. So whenever we encounter vacuolated cells in the cytology smears, especially in an elderly female or male, it is prudent to sample the lesion thoroughly so that making an inappropriate diagnosis can be avoided.
Thank you, Dr.
Listening
Fenila.
to you, will anybody do so much of a study in an FNAC material, ma? Because when you do an FNAC,
Yes,
they
sir.
want the report within 24 hours, right?
Yes, sir. Yes, sir.
Where will you have the time to go through all your, armamentarium of so many, depending upon the morphology to run so many markers, it is not possible. You
Yes,
have to
sir.
have only, and
Biopsy,
moreover,
yes, sir.
FNAC has
Yes,
its
sir.
own limitations. So
Yes,
you can only say to certain extent whether it is positive, negative, what are the possibilities.
Yes, sir.
And another thing is
Actually, with
apocryne.
FNAC, we should not jump into a conclusion thinking that is benign. We have to be
No,
very
see,
cautious.
that will come with experience, ma, and also
Yes,
with the
sir.
clinical correlation.
Yes,
See,
sir.
that is why we go, we always ask the radiologist opinion, we
Yes, sir.
ask the clinician, we see whether the patient, and we do the FNAC, so we can look at the patient, right? That
Yes,
is one
sir.
thing. Second thing is, your apocryne carcinoma is very common in the postmenopausal age group.
Yes,
So
sir.
we recently had, I'm sure Impana, I don't know whether she's still there or she has left. We recently had a case of same type, invasive ductal carcinoma with apocryne differentiation. So,
Yes, sir.
and you said papillary and all that, nothing, no pattern was there in any of your slides.
Yes, sir.
Your slide showed only a clear cell pattern and some kind of a sheet of cells with a well-defined cytoplasmic border.
That's only for discussion. Our case didn't have, ma'am. If there is, along with the vacuolated cells, if there is, I discuss, our case didn't have, ma'am.
Secretary carcinoma kuda
Just for
DD
discussion.
No, other one, K67 did you do for this case? No.
Yes, ma'am. Yes, ma'am.
What was the percentage?
Actually, it was between 30 to 40%, ma'am.
High only.
High, yes, ma'am.
But you didn't do that GCDFP positivity.
Only
No,
GCDFP was not done, ma'am. But
yeah,
AR
that is
and
actually more confirmative,
Yes, ma'am.
that is more
The
confirmative.
patient,
because,
yes, ma'am. Patient
quite
already
obviously.
spends too much, so we did
And
AR.
and another thing is, was it looking very frankly malignant?
Yes, ma'am, clinically.
Yeah. See, otherwise, there are a lot of breast cancers which can mimic your sweat gland tumors and things like that,
Yes,
myoepithelioma and things like that, adenoid cystic carcinoma, all that has been reported. And clear cell myoepithelioma can also be included as one of the differential diagnoses in this because of the clear cell pattern. As Adil said, secretary, another thing also. So, see, these are the things which have to be discussed. And your FNAC really made me laugh because you discussed so much about FNAC with so many markers. It is really difficult. And the cell block also may not be very yielding, to have so many markers to be done. Anyway, it was good. It is an eye opener for all people who deal with these kind of cases. Good.
Yes, ma'am.
Thank you, Dr. Femila. Thank you for that nice presentation. Can we go on to the next case? Next presenter, Dr. Lakshmi. Lakshmi from Rela.
Yes, ma'am.
Lakshmi, please share your screen, please.
ரொம்ப டைம் ஆயிடுச்சு.
இன்னும் ஒரு case now, madam. Just one more case. The one
After Lakshmi, one more, Avalar.
After Lakshmi, we have one from Dr. Gayatri from ESI. That's it.
Can you see my screen, ma'am?
Yeah. Yes, Dr. Lakshmi.
Good afternoon, all. So this is a 69-year-old male with complaints of loss of weight, appetite, and altered bowel habits for 6 months. So he came to us on December 2021. So the ultrasound abdomen revealed a hypoechoic lesion which measured about 7.4 centimeter in the left lobe of liver, and contrast-enhanced CT showed hypodense lesion in the left lobe of liver which measured 8.7 centimeter, involving the segments 2 and 3 limited to the liver. The patient then opted for native medications for 6 months, and then he came back to us, after which the repeat CT was performed, and there was an increase in tumor size, which measured around 12.7 centimeter in maximum dimension. So here, these are the CECT images. In the arterial phase, we could make out the left lobe of liver is showing a hypodense lesion with a thin peripheral rim of arterial enhancement. And in the delayed phase, we could see a progressive centripetal filling in the lesion. And in the third image, the tumor is infiltrating into the gastric wall with loss of fat plane. So the PET CT, it showed no uptake in any other site, after which the patient underwent left hepatectomy. So the specimen came to us, and this is a gross finding. This is a slice of a liver, which is showing. This is a slice of a liver showing a tumor, pale brown in color with pushing borders. The tumor shows around 40 to 50% areas of necrosis. And in the right side, we could make out there is an attached fat and fibrous tissue with tumor infiltration. So the microscopic finding on the lower part, we could make out the normal liver parenchyma on the left side. The right side, a diffusely infiltrative tumor is noted. This again, the normal liver parenchyma is noted on the top, and the bottom showing a diffusely infiltrative tumor with geographic areas of necrosis. So this is the section from the attached portion of fat. So we were able to see the gastric wall with tumor cell infiltration into the muscularis propria. On the higher part, we could make out the muscularis propria of the gastric wall that is infiltrated by the tumor cells. Coming to the higher part, so we could make out the normal hepatocytes on the left side that is infiltrated by the tumor cells. So coming to the morphology of the tumor cells, so the tumor cells, they were predominantly spindle-shaped with moderate amounts of eosinophilic cytoplasm, markedly anisomorphic vesicular nuclei with prominent nucleoli. So this is again the spindle-shaped tumor cells. So we could make out the bizarre tumor cells, binucleate forms, hyperchromatic forms. So the arrows indicates the brisk mitotic activity that is going on within the tumor cells. So in the lower part, we could see, on the left side, we could see the hepatic vein that is infiltrated by the tumor cells indicated by the arrow. So here, on the higher part, we could see the wall of the hepatic vein, the muscular layer of the vein that is infiltrated by the tumor cells. So with all these histomorphology findings, this was a very poorly differentiated tumor with predominant spindle cell morphology, which showed vascular invasion and also infiltration into the adjacent gastric wall. So we then ran a panel of IHCs. The tumor was positive for Vimentin. There was patchy positivity for pan-cytokeratin. IMP3 was also positive, patchy positivity. IMP3 also showed patchy positivity, and arginase was positive in rare cells. So this is PDL1 IHC, which was positive, which was diffusely positive in all tumor cells. It showed a strong membranous positivity. So in order to exclude the other primary sarcomas of liver and other primary tumors, we ran an extensive panel of IHCs, and all were found to be negative. After this, we gave the final diagnosis as primary hepatic sarcomatoid carcinoma. So the patient was then started on adjuvant pembrolizumab therapy, which is an anti-PD-L1 therapy. He completed 6 cycles, and now it is like 1.5 years post-surgery, and the patient is currently doing well. There is no distant metastasis. There is no local recurrence. And 3 months back, the patient also had PET-CT, which was completely normal. So we also did the tumor genomic characterization as a part of the research study that is going on in our institution. So the molecular alteration of this aggressive cancer subtype, they are not well understood. So a comprehensive tumor genomic data analysis was performed. The whole exome sequencing of DNA and RNA was performed from the tumor tissue along with the peripheral blood DNA for germline analysis, which revealed 3 pathogenic gene alterations, which were P53, NF2, and MATE-C3, indicating their potential role in the pathogenesis of the tumor and also the tumor aggressiveness. So the tumor was negative for the microsatellite instability, and also it had a low tumor burden mutation score. Tumor mutation burden score. So a few points about primary hepatic sarcomatoid carcinoma. It is an extremely rare and aggressive subtype, accounting for about 0.5 to 3.9% of primary hepatic malignancy, with a very uncertain pathogenesis and poor survival. So the overall survival of these cases are 8.3 to 10.5% according to the literature study. These tumors, they have both epithelial and spindle cell component. The epithelial component can be hepatocellular, cholangiocellular, or mixed or unclassified. The spindle cell component, they can be poorly differentiated carcinoma with spindle cell appearance, anaplastic spindle cells, bizarre multinucleate tumor giant cells, or they can be differentiation towards mesenchymal lineage like leiomyosarcoma, rhabdomyosarcoma, fibrosarcoma, osteosarcoma, or chondrosarcoma. So in the literature study also showed that these tumors can arise because of the dedifferentiation of carcinomatous element of the primary liver tumor in which they have given the locoregional therapy. So these tumors, they also exhibit a very larger size, atypical imaging findings, early recurrence, frequent metastasis, and dismal survival. So a few words about the program Death Ligand 1. The program Death Ligand 1, it binds to PD-1 and plays a pivotal role in maintaining the peripheral and central immune tolerance. So this is a image which is showing a cancer cell that is having PD-L1 on its surface under T cell. It's a cytotoxic T cell that is having PD-1 on its surface. So usually when a cancer cell don't have this PD-L1, the T cell receptor of the T cell and the MHC that is present on the surface of cancer cell, they interact, leading to activation of the adaptive immune response, resulting in killing of cancer cell. But when the cancer cell possesses this PD-L1 on its surface, it interacts with PD-1 on the surface of T cells, leading to activation of inhibitory kinases, and thus resulting in activation of immune suppression. So this anti-PD-L1 therapy, it plays a role in this point where it can block this interaction between PD-1 and PD-L1, resulting in activation of adaptive immune response and killing of cancer cells. So this is a case report. It's a report of 4 cases. It's a lymphocyte-rich hepatocellular carcinoma in which we found frequent expression of PD-L1, which was recently published in Annals of Diagnostic Pathology. And so, these lymphocyte-rich hepatocellular carcinomas are also poorly differentiated hepatocellular carcinomas. So it's evident from these 4 cases, and also from the cases which we presented just now, which is the hepatic sarcomatoid carcinoma. It is evident that the use of PD-L1 immunohistochemistry, they offer a great role, as when these PD-L1 IHC comes positive in these cases, the anti-PD-L1 therapy can be offered to the patient, which can prevent the post-operative recurrence, and they can also play a great role in unresectable and in metastatic cases. So to conclude, the hepatic sarcomatoid carcinoma is a rare HCC subtype with highly aggressive features. So the histologic subtypes of HCC, they're very closely related with the molecular alterations, the oncogenic pathways, and the transcriptomic subclasses, which are G1 to G6. The genetic alterations, that is in P53, they suggest the spindle cell component arise from the transformation of carcinomatous components, and the tumors which have these P53 mutation, they usually belong to the transcriptome subclass of G1 to G3, which are highly aggressive tumors with high proliferative activity, as seen in our case. So we just presented this case to enhance the understanding of the molecular mechanism that is underlying this hepatic sarcomatoid carcinoma, and also the benefit of immunotherapy in patients with HSC and also in other poorly differentiated malignancies. So in this case, the tumor cells were diffusely positive for PD-L1, and the patient also benefited from anti-PD-L1 therapy with a survival of around 16 to 17 months, which is not seen in any other cases of hepatic sarcomatoid carcinoma. Thank you.
Lakshmi, where is your carcinoma part of it in these sections?
Ma'am, yes, ma'am. This case, the hepatic sarcomatoid carcinoma, they can have both epithelial and spindle component, but they can also have pure spindle component in the tumor cells, ma'am. So even after extensive sampling, we couldn't find out any carcinoma part of the tumor. The only thing which we were able to see was the patchy pan-CK positivity and arginase positivity in few cells.
So that why can't you just call it a sarcoma, primary sarcoma of the liver? Because of the histochemistry CK positivity, you are calling it a
no. Yeah, madam, this is Mukul, ma'am.
Yeah, yes, Mukul.
Ma'am, yes, ma'am. Actually, ma'am, in primary liver cancer, the sarcomatoid is a variant which can show, if primary liver cancer, sarcomatoid can show some areas which can be carcinoma like, means epithelioid like cells or epithelial cells in groups and sheets, and also they can show pure very few tumors can show pure spindle cell areas also. After, in this case, extensive sampling was done and no carcinomatous like area was diagnosed. Why it is not sarcoma?
See, that is my question,
Pan-CK expression, ma'am.
Why can't you just call it a sarcoma? Why do you want to call it sarcomatoid carcinoma?
Have you done P53 to say it is a
pan-CK expression was there, ma'am, in the tumor?
But that was not very.
That can be patchy, ma'am. That if we have to classify as primary sarcoma of the liver, we need to find some lineage. This everything was excluded from the liver. These tumors actually, ma'am, are extremely rare, and they can show patchy pan-CK expression also.
Okay.
Ma'am, even in oral cavity, no, ma'am. Like we see sarcomatoid carcinoma of the oral cavity, no. There also again the same thing happens, ma'am. Squamous differentiation need not be demonstrated, and patchy pan-cytokeratin positivity will make us call it a sarcomatoid carcinoma.
That
Still,
means,
even if there is.
so that means only IHC makes the diagnosis of a carcinoma.
Yes, ma'am.
Yes, ma'am. Sarcomatoid carcinoma, yes, it is the case, and even in uterus for that matter.
Yeah.
Breast and all such things. Thank you.
Without an IHC, it's very
Yeah. I think Edil, you and I have to take a retirement, I think.
நம்ம ரெண்டு பேர் தான் இன்னும் கொஞ்சம் படிக்கணும் போல. நீங்க வேற.
Eternal learning.
After some years, when your artificial intelligence comes and everything is only molecular, I don't think pathologists will have any role at all.
No, ma'am.
No, Pita, both of us are slide. When you look at the slide, we think of an each cell and we are describing, and we wanted to give the clinical, histopathological diagnosis base. But these people are doing IHC and confirming it and arguing and what shall I say? They say it is in the case Madri.
Anyway, it's good. We are learning a lot of things, from all these people.
Yeah,
I should thank all of them. Yeah.
Thank you.
We are attending for the benefit only from junior.
Yeah, it's just in a lighter note. Don't take anything amiss. It's only a lighter note.
Thank you,
ma'am. Thank you, ma'am, and thank you, Dr. Lakshmi, and thank you, Mukul sir. But anyway, histopathology is the mainstay from where we build all these IHC markers. So we go on to the next case, Dr. Gayatri from ESI. That's the last case of the day. Dr. Gayatri, please share your screen.
Good afternoon, ma'am. Am I audible, ma'am?
Yeah, you're audible, but your screen is not, please.
Visible.
Yeah, caught red-handed.
Yes, ma'am. Yes, ma'am. Good afternoon to one and all present here. I am Dr. Gayatri from ESI Medical College, guided by my professors Dr. R. Priyavardhana, Dr. A. Satish Selvakumar sir, and my professor HOD Dr. K. Meenakshi Sundaram sir. Today I am going to present a case titled as Caught Red-Handed.
Slideshow mode, ma.
Yes, ma'am. A 38-year-old female presented with swelling in the right infraaxillary region for a week and was clinically diagnosed as lipoma. The local examination revealed a firm swelling of 2 × 2 centimeter with mild tenderness, not warm, and it was not mobile. FNAC was done on 1st of August. This picture shows the smears from the aspirate, showing clusters of mature adipocytes and scattered inflammatory cells in the background. And the final impression was given as lipoma in the right infraaxillary region. Excision biopsy was done on 14th of August. We received a single soft tissue mass measuring 2 × 1 × 0.7 centimeter, which was all embedded, and the cut section was gray, white, and firm. This is scanner view of the section from the specimen, which showed fibrofatty tissue. Strikingly, this doesn't look like a lipoma. And here, this is a hyper view showing multi-threaded giant cell and dense aggregates of histiocytes, lymphocytes, and sheets of eosinophils. Other foci also showed a peculiar structure. We can see this peculiar structure containing eosinophilic material with a wall, which on high magnification, it confirmed it as a parasite.
The hepatococcus.
The parasite. It is a parasite with chitinous wall with longitudinal ridges.
Yes, now I know.
And this is the intestinal part of the parasite. This is the wall with the transverse ridges. And deeper sections showed similar structures. These are the parasites in the background of dense inflammatory infiltrate and eosinophils. On working up a differential diagnosis, first is onchocerca. This is the image of the onchocerca volvulus. It has transverse striations with annular thickening. We can see a thickening inside the inner layer. And this is a double barrel uterus of the onchocerca volvulus. And this is not the case with this picture does not match with our case. Second is lower. We can see this is the parasite having a very thin cuticle. And so we excluded this. Next is trichinella spiralis occurring in a muscle. This picture, which shows a nurse cell or nursing cell containing the encysted larvae. Next is myiasis. Myiasis is caused by fly larvae or maggot. We can see the worm having thin cuticle with spicules on the external layer. So these different diagnoses doesn't match with our case. After reviewing the literature with occurrence of parasites in the subcutaneous tissues, we came across a parasite with similar morphological features as our case, and we confirmed it as Dirofilaria. And the final impression was given as chronic inflammatory pathology with parasitic infestation, the morphology favoring Dirofilaria. Let's see a small discussion about human dirophilariasis. Human subcutaneous dirophilariasis is a rare and emerging zoonotic infection caused by filarial worms of the genus Dirofilaria. Dirofilaria are nematodes that belong to the family Onchocercidae. The most common species are Imidis, Repens, Tenuis, Conjunctivae, and Ursi. Among these species, Repens is more commonly associated with human dirophilariasis. In India, only 73 cases have been reported, and infection is emerging in southern India. We can see the life cycle. First, dogs are the primary host of the Dirofilaria. we can see the adult worms live in the nodules under the skin, and it releases microfilaria in the blood. So dogs containing peripheral microfilaria. Now the mosquito takes up the microfilaria from the infected dog, and the microfilaria develops in the mosquito, and then the mosquitoes transmit the infection to the next host. So now man acts as the accidental host and the dead end host. When the infection occurs in man, it often causes subcutaneous nodules, and the worm gets dyed in the subcutaneous nodules, and it forms a granuloma reaction. And we can also find this kind of granuloma reaction in other organs like lung, liver, as well as in eye. Transmission. The dogs and cats are the primary host. The parasites are transmitted to man by infected mosquitoes. Humans are the accidental host here, and the parasites undergoes incomplete development in humans. So the microfilariemia is not seen in humans. The manifestations are painful subcutaneous nodules on face, eyelids, upper arms, thighs, and abdominal wall. In lung, it occurs as pulmonary granulomas. We can see the dying worms producing granulomatous reaction here, which appears as a coin lesion in the chest X-rays. It is often misdiagnosed as a like malignancy or a pulmonary nodule. Often it is an incidental finding. It also present as ocular granulomas in periorbital, subconjunctival, and intraocular regions. And the definitive diagnosis is made by excision biopsy and histopathological examination. And peripheral eosinophilia is very rare in pulmonary diarrheaphiliasis, and microfilaria is very rarely seen in blood. And by prevention, health education to the people and deworming the animals in the endemic areas, no specific treatment is generally necessary in human diarrheaphiliasis. It's often self-limiting. In case of subcutaneous nodules, we can offer surgical excision. In symptomatic management can be done for pulmonary diarrheaphiliasis. However, single dose of ivermectin and 3 doses of diethyl carbamazine can be given after confirming the diagnosis. These are the similar case reports in India of human subcutaneous diarrheaphiliasis in Kerala and Karnataka and in Kolkata. And I sincerely thank my respected faculty for giving me this excellent opportunity to present in this meeting. These are my references. Thank you, ma'am.
Thank you, Dr. Lakshmi. Thank you. So we have finished with diarrheaphiliaria of the liver.
Lakshmi, I think the presenter was somebody else. Valar Gayatri,
I'm Gayatri, ma'am.
I'm sorry.
Okay.
It was Dr. Gayatri. Thank you, Dr. Gayatri.
Thank
Where
you,
are you?
thank
You're
you.
gone.
The previous case.
Anyway, one point of well, I will say that eye opener is whenever you find anywhere in the soft tissue or anywhere so many eosinophils as you have seen in this case, you have to definitely think of some parasitic or whatever that
Yes, ma'am.
infection. You have to definitely consider filariasis, anything.
Eosinophils is an indicator.
Yeah, that is an indicator. Definitely, fungus. You have to think.
You must always
Any of them, you have to think of that. Apart from the eosinophilic granuloma, which is a different entity altogether, whenever you find tissue eosinophilia so much, you definitely have to think, especially when you have so much of inflammatory cells, histiocytes. You have to think of some organism. That is a take-home message. Very nice case. Very interesting also.
Thank you.
So thank you, ma'am. So we close the session with a very interesting case, and we have had 3 cases from the liver this time. One embryonal sarcoma of the liver, one is sarcomatoid carcinoma, a rare one, and again this is also a rare one, diarrheaphiliaria of the
And
liver.
this is from, excuse me, ma'am. Ma'am, this is from right infraaxillary region, ma'am.
Not
liver.
Not in liver.
It's
liver. இது வந்து subcutaneous axilla.
Okay.
From the soft tissue.
Thank you, Seema ma'am, and thank you, Edil ma'am, and thank you so much, Chandra ma'am, for your
Thanks for that.
for all the help.
Thank you,
ma'am.
Thank you so much.
Saranyan, and thank you, Dr. Francis. It is all, there was a little hitch in the beginning, and thank you so much. Thank you, ma'am. Thank you. Meet next time.